spends 1 week. Domain 3, domain 4, domain 5. Concepts you can spend 1 week at least starting. Rather than spending the lot of time on the coding, who are spending more time on the domains, they are clearing exams very easily. Who are not spending much time on the domains, it was difficult. Okay. Domains was very important here. So I'm not recording today's sessions onwards, guys, because I already shared the provider queries recordings. Okay. Hope you understood, right? Same concepts I already explained and I already shared the recorded also. Just I will explain, listen. Because provider queries already I shared the recording. Yes, yes.
Sir, yesterday record.
Everything I shared yesterday record also I shared, check.
No, sir, I don't.
In which group you are? Actually, no. I put 26th date by forgot. It was 25. Okay.
Okay, sir. Okay.
I mentioned the date wrong. Leave it, but concept should be same. Okay. Date I mentioned wrong. So now we can discuss about provider queries. So first, what is the query? When we need to raise the query, what is the query, types of queries, how we need to raise the query, everything we can discuss today. Okay? And I am not recording today's session. Remember, I already shared the provider queries. You can watch it. From here. Provider query. Provider means first we can discuss. Okay. Provider means who treated the patient. We can consider as provider or physician. Correct? Who treated the patient. We can consider as provider or physician. Here we have two different types of providers. Attending provider and other treating provider. Attending provider, attending or admitting, same meaning. Attending or admitting. Provider or physician, same meaning. Okay. So who gave the inpatient admission? Who admit the patient in hospital? That physician should be attending or admitting physician. That physician should be attending or admitting physician. Other than the attending physician. Other than the attending physician. Who treated the patient? That remaining all providers considered as other treating providers like consultants, radiologist, pathologist, nutritionist. Okay. These all are considered as other treating providers. Who treated the patient? Considered as
Admitting, attending provider.
Attending provider or admitting provider, same meaning. Other than the admitting provider, who treated the patient like consultant, radiologist, nutritionist, pathologist and all considered as other treating providers. So first thing, always we need to raise the query only for attending provider. Always we need to raise the query for attending provider. Okay. Always we need to raise the query for attending provider. Why? Because tell me anybody. Why we need to raise the query for attending provider rather than consultants or radiologist?
He is the main
Control for that patient.
Because who admitted the patient, that physician only responsible for the patient. He need to take care of everything in the note. Suppose consultants means like some department consultants will come and they will check their views and they will give their impression and they will leave. But what they given, it should not be exactly correct or wrong. We need to check, right? Attending patient must review the documents. Suppose pathology or radiology taken the radiology service and they return their diagnosis or their identification or their findings. Then that findings, whether it was correct or wrong, attending patient need to check. If it should be correct, they can finalize. If it should be wrong, they can't mention. So default, we should not code, and default, we should not raise the query for other treating providers. Always raise the query only for attending provider or attending physician. First thing. Next, whoever find the findings other than the attending physician, like pathology note, radiology note, or consultation note, we should not code directly unless attending patient reviewed. If attending patient reviewed that diagnosis or document, we can code. Suppose pathology document mentioned cancer. Can we code directly from the path report?
No.
No.
We should not code path report, radiology reports and all. Attending patient review must be documented. This remember. If any finding you found in the path report, for that document, raise the query to attending physician. Okay. Next. Type of queries. Note down. Type of queries. Sorry, before that, what is the query we can discuss? Provider correct na? Query. A physician query is defined as written question to physician. We need to raise the query to physician or written questioning to physician to obtain additional clarifying documentation to improve the specificity and completeness of the data used to assign diagnosis and procedure codes in the patient health record. Okay, this is important. A patient query is defined as a written question to physician to obtain additional clarifying documentation to improve the specificity and completeness of the data used to assign diagnosis and procedure codes in the patient health record. Then, a query is a communication tool between the coder and provider to clarify the documentation. A query can be a powerful communication tool used to clarify the documentation in the health record and achieve accurate code assignment. When we need to raise the query, incomplete, illegible, or conflicting documentation, if you found, we need to raise the query. Now, next concept. Document was very clear, guys. There is no issue in the document, but the issue was coder side. They are unable to find whether it was codable or not. Can we raise the query?
No, sir.
No. Okay. Is there necessary in the documentation? Only we need to raise the query. If the document was clear, if the coder unable to find or a coder unable to understand the concept, they need to ask their supervisors. They should not raise the query. We should not ask the query for our doubts. Is there really necessary in the document? Document have problem. Then only we need to raise the query. Next. This concept. Golden rule of query. Okay. If it's not documented by the physician or provider, it didn't happen, which means anything not mentioned in the document, not documented in the record, which means that not done. Not documented, not done. We should not assume anything beyond the documentation. We should not assume. Whatever you find in the documentation, that only we can code. Don't code assume. Okay. don't think beyond the document. Suppose they given the insulin in the medication. Okay, insulin you mention in the medication. For which diagnosis we can use for the insulin? Diabetes. But there is no diabetes in the record. Can we assume the diabetes based on insulin?
No.
No. Okay, we should not do like that. We should not argue why they will take the insulin without diabetes. They are wrong. We should not argue like that. Whatever they mention in the record, we can quote. That's our duty. Clear? Not documented, not done. What they documented, that's it. Next, types of queries, note down. Here you will get 2 questions, guys. Types of queries. Queries may be either verbal or written. Verbal means
Mouth. You have to.
Asking directly to the physician.
clear. Clear, guys. Verbal means audio, voice. Okay, voice message if you send to the patient, it should be the verbal. Written means
Sending mail.
Document.
documented. Okay, printed. It should be the written. So we can raise the query either verbal or written. But we need to get the reply default in the written format. Okay, default in the written format. Always we can get the reply in written format. Okay, if they raised verbal or written, provider must be give response in the written. Why they need to give the response in written?
Proof.
Why if they said provider also you can code means we can we accept in the verbal?
No.
No.
Because we
Written.
need the document proof. Okay, while we are coding, we need the document. So provider must give the response in written only. Next, types of queries. First query, concurrent query. Concurrent query. What they are saying about concurrent query?
While patient is still on inpatient admission.
While you are raising the query, patient was still in the hospital. Before discharge itself, if you raise the query, it should be considered as concurrent queries. Okay. So who will raise the concurrent queries now? Generated by CDI specialist. Generated by CDI specialist. Generated by CDI specialist. Clear? Suppose if the patient was already discharged from the facility, if you raise the query, what type of query? After discharge from the facility.
Re.
Written.
After discharge from the facility, if you raise the query, what type of query?
Retrospective.
Retrospective. Retrospective query. Or post-discharge query. So here, first thing guys, while you are raising the query, patient still in the hospital, that type of query is considered as concurrent queries. These queries should be real time, day-to-day queries. These queries generated by CDI specialist. CDI means clinical documentation improvement. This team will work for hospital side. They will generate the queries day to day, immediately. They will resolve the documentation issue immediately. Suppose, if you raise the query after the discharge, before claim has been submission, it should be retrospective, like medical coders. While we are working, if you raise the query, it should be retrospective because you will get all the discharge summary, everything while you are coding. But before the claim has been billed, because coder finalize the document will go for the billing. If you raise the query, we should not complete the document. We can pend for the clarification. Once clarification was resolved, we can finalize for the billing. Next, post billing means after the completing the documentation. If you raise the query, it should be post billing. If you submit the document, it will go for the billing. But internal audit or client audit open and they find the query opportunity and they raise the query. It should be post billing query. After billing, after submit to the billing, if you raise the query, it should be considered as post billing queries. Before discharge, concurrent queries. After discharge, retrospective queries. After billing, post billing queries. Go through these three types. Any doubt, ask me. Any doubt?
Sir, post initial billing queries also raised from the CDI specialists.
Internal audit or external audit. Okay, it's not CDI. Whoever, both can raise. CDA means these all are before rising only CDA. After billing, it won't go for the CDA. Internal audit or client audit. If you open, it should be post initial billing. Clear? Huh? Here they mention, see, post billing queries initiated or developed by internal or external audit. Okay. Next, note down types of queries based on documentation issues. Whatever we are going to discuss now, these type of queries we can raise based on the documentation issue. Based on the documentation issues or documentation need. These type of queries we can raise now. Okay, first query, note down clinical indicator query. Clinical indicator query. Clinical indicator query. So guys, suppose if you are working in outpatient, you found the documentation related symptoms and medication, but they not mentioned anywhere in the diagnosis. Can you assume the diagnosis to code?
No.
No. And can we pend the clarification? Or you will raise the query or you will code symptoms in outpatient?
The query.
In outpatient,
No, we can go with the symptoms in outpatient.
in outpatient, we can go with symptoms. We should not raise the query.
Yes.
Okay? While you are working in inpatient, but IPDRG, they not mention diagnosis anywhere, but they given the diagnosis related symptoms or medication or diagnostic workup, lab test. Based on that, we should not code here also, but we can raise the query for particular condition. Based on documentation symptoms, we can raise the query for particular condition. So how many symptoms or how many indicators must support to raise the query? Minimum 2 indicators must support. Based on one symptom, we should not assume the condition. Minimum 2 indicators must support to raise the query. So clinical indicator query, first heading note down. Clinical indicator query. Clinical indicator query. Clinical indicators are nothing but sign and symptoms, diagnostic or therapeutic options of a particular diagnosis. Diagnostic studies are therapeutic options of a particular diagnosis. Sign and symptoms, medication, diagnostic workup. Anything if they documented relating to the particular diagnosis, minimum 2 indicators if supported. Based on that, we can raise the query for particular condition. I will show one example, then we can start the question discussion. Check the 29th. What diagnosis we can raise?
HIV, sir.
Based on what criteria we are going to raise HIV?
Based on HIV, the Kaposi sarcoma is a manifestation of HIV.
Based on therapy,
One indicator.
Retroviral therapy has been given, so any viral infection could be the reason.
Antiretroviral therapy, this is. Antiretroviral therapy we can use for the HIV treatment. Correct?
Yes.
Viral disease was HIV. Antiretroviral therapy we can use for the HIV. And Kaposi sarcoma also manifestation of HIV. So we can raise the query for HIV. Check 5th question.
heart failure.
Heart failure, sir.
Correct. Correct, guys. Because based on echocardiogram, LASIK, ejection fraction, this all are
Lower
symptoms of
CHF symptoms treatment.
treatments of CHF, symptoms of CHF. So we can raise the query for CHF. One last question.
మా బజ్జీ తిను
Check the 15th question. Last question. 15th one.
Is acute renal failure linked to diabetes?
Hypertension. B, sir.
Hypertension. Does patient have hypertension? Because they mentioned lisinopril and the blood pressure also monitored. Correct? So
బ్లడ్
we can raise it.
శివ గారు అక్కడ బ్లడ్ షుగర్ అని కూడా మెన్షన్ చేశారు. బ్లడ్ షుగర్
Already
అండ్
patient have diabetes, right?
ఓకే ఓకే.
History of diabetes patient have. No? You get idea?
Hello.
Yes, yes.
Yes.
Sir, why can't we query is the acute renal failure linked to diabetes?
Where they mentioned acute renal failure here, it was not a default condition, right? Acute renal failure will not develop due to diabetes. No, only chronic renal failure we can assume. Acute renal failure, if they mentioned linking, we can go with. Otherwise, we can raise the query. But here, we can choose mostly hypertension based on the indicators rather than the acute renal failure.
Okay. Sir.
Actually, you can raise the query for acute renal failure and diabetes linking also. Okay, cause and effective relation, that one.
Yeah, that's a question I was asking.
That we can discuss at cause and effective time. Okay.
Okay. Sir.
It was clinical indicators we are discussing. No? If I tell that also, no, if people will confuse who don't know the IPDRs. One
Understood.
concept we can cover. Okay.
So based on indicators, we are querying it as hypertension, right?
Correct. Next. Exam related conditions for which diagnosis related, you will get the questions. Okay. First one, note down the indicators. Sepsis, you will get one question. If you want to note down the indicators, note down, or take the snippet, take down. Or I already shared the document inpatient. The document name should be inpatient. Here you will get the condition names. Sepsis related, you will get the question. Read once all the indicators, guys. Noted sepsis. Next, aspiration pneumonia note. Aspiration pneumonia. Esophagitis, dysphagia. Two noted. Vomiting, swallow study. Any oral disorder, GERD. If the patient present with pneumonia, check for the aspiration pneumonia. This also note down. Anemia, acute renal failure, you don't get. No need to worry. Okay. Whatever I said for that diagnosis only you can note down. Because we can't able to read all the diagnosis related indicators. Clear?
Yes.
Next note down CHF. Congestive heart failure note down. And remember the ejection fraction values, guys. Based on this ejection fraction only, we'll get the question. Noted? Thank you. Next condition. Hyperkalemia, note down. Hyperkalemia. Hyperkalemia, please note down. It was not mentioned in the inpatient document. Clear? Noted, guys. Hyperkalemia.
Yes.
Thank you. Based on these conditions related clinical indicator queries you will get. Next, POA indicator query. Whenever your document was insufficient, whenever you are identifying the POA, document was insufficient, what indicator we can raise? U indicator, correct?
You.
If you add the U indicator, we must raise the query. If we add the U indicator, we must raise the query. Same concept here also applicable. Okay. If you add U indicator, we can raise for the POA status query. POA indicator query we can raise when the documentation is insufficient to identify the POA status. Okay. Next query, note down. Acuity or specificity query. Acuity or specificity query. Next time. Acuity or specificity query. Acuity or specificity query. What is the meaning of acuity or specificity? Read
To
and tell me
determine-
that 4 lines.
And chronic. For
What they mentioned, read that 4 lines and tell me.
To determine the exact specificity of the code so that we do not code any unspecified or default code.
Then any other answer? To establish a acuity or specificity of a documented diagnosis, they are saying when whatever the diagnosis they documented, we can identify the specificity or acuity to avoid default unspecified code, which means if they mention any diagnosis, look always for the specific type of the diagnosis, specificity for the particular diagnosis. Do not code default unspecified code. They are saying, suppose they mentioned unspecified diagnosis. There is no specificity, there is no type anywhere in the record. what we are doing generally? Suppose they given CKD unspecified stage, what you will code?
If the GFR value is given, so you can raise a query.
Generally, what we will do, we can code unspecified type, right?
Yes.
Outpatient. Okay. If they mention any unspecified diagnosis like CHF, respiratory failure, CKD, they not mentioned any types, we can go with unspecified and we can submit. We should not look for the specificity. We should not raise the query for specificity. No. If they're available, we can code. If not available, we can code unspecified. But in inpatient, while you are working in IPDRG, do not code default unspecified. If there is no specificity in the record, but the particular condition have more specific codes in the ICD-10-CM index. Okay, there is no code in the document, but the condition have more specific codes in the ICD-10-CM index. We can raise the query for particular diagnosis specific type. We can raise the query for the diagnosis particular type. What type of diagnosis patient have? We need to raise the query. For example, note down CHF, CKD, pneumonia, respiratory failure. You will get question from the respiratory failure, guys. They will give assessment, patient have respiratory failure. What you will do? They will ask. We can raise the query for respiratory failure. Any doubt, acuity or specificity query?
No, sir.
Clear, right? Acuity or specificity. Clinical indicator.
repeat చేస్తారా?
Respiratory failure. They will ask the question related to respiratory failure. They will give assessment unspecified respiratory failure. How you will code the scenario like that.
Okay.
I will show the questions. Don't worry. Every question I will discuss at the time of paper review. Next query type, note down. Cause and effective related query. Next, note down cause and effective related query. What is the meaning of cause and effective, guys? Cause and effective means?
Relationship.
What relation between the two medical conditions, correct?
And manifestation. Yeah.
While we are coding the multiple diagnoses, we need to look the two conditions was related or unrelated. Sometimes we can default assume the relationship, correct? For the two medical diagnoses, sometimes we can assume the default relationship, yes or no?
Yes.
Yes, sir.
Give me some examples for which related diagnosis we can assume the default relation. Which diagnosis?
DM with ulcer.
DM with CKD, DM with osteomyelitis.
DM, ulcer.
Heart failure,
Heart failure with hypertension.
Hypertension.
hypertension, CKD, heart
CHF,
failure.
hypertension, CKD combinations. Correct? CHF, hypertension, or hypertension,
CKD, anemia.
CKD, anemia.
Neoplasm anemia.
Neoplasm anemia can default. Neoplasm anemia, we should not assume. If they documented anemia due to neoplasm, we can code. Okay. we can resume default like DM combination, CHF, CKD, hypertension, this type of combination we can assume default. For some combinations, what they need to do? They need to must document the relationship, correct?
Yes.
For some diagnosis, they must document the relationship. The diagnosis due to the particular diagnosis. Suppose they given DM and cellulitis. Can you code relation?
No, we lost query.
We should not code default, right?
Yes.
Yes.
Combination we should not code. If they documented cellulitis due to diabetes, you can go with complication. Correct? You
Yes.
code DM neuropathy default, but we should not go for the DM and cellulitis default complication, right? So whatever the diagnosis combination must document the relationship. Okay. For combination, must document relationship, but they not mentioned in document related or unrelated. We can raise the query for relationship. We can raise the query for relationship. It should be cause and effective relation query. Whatever we can assume default, you can assume and code. Do not raise the query. For which combination they must document the relationship. If they not mention the relation, whether it was related or unrelated, at that time only we can raise the query. If they said clearly related, we can code. If they clearly said unrelated, code separately. If they may not mention whether related or unrelated, so they given simply diabetes and cellulitis, diabetes and acute renal failure, diabetes metabolic acidosis, sepsis, acute renal organ failure. They not said anywhere it was related or unrelated. At that time, we can raise the query. Got it? అర్థమైందా అండి cause and effective relation for everyone?
Yes.
Thank you.
Right, sir.
So note down the examples. Note down the examples. Sepsis plus acute organ failure. Not mention the relationship. We raise the query. Okay. Suppose they mentioned sepsis and acute organ failure. Organ failure due to sepsis means how we can code?
Sepsis,
Severe sepsis, organ failure.
Yes, sepsis acute.
If they not, if they documented organ failure clearly unrelated to the sepsis, then
sepsis alone.
We should
We will
query
write
for
query. Severe sepsis alone.
organ failure. Severe sepsis query we can write.
if they clearly unrelated, why you need to raise the query?
Sepsis
The
alone.
third failure is due to
Both
sepsis
sepsis
or
and
not?
organ failure, that's it, okay? If they said organ failure due to some other condition, suppose patient has sepsis, acute respiratory failure due to COPD exacerbation, they documented. Okay, acute respiratory failure due to COPD. They are clearly said acute respiratory failure was unrelated to the sepsis. Then you code sepsis, organ failure, that's it. No need to code severe sepsis or no need to raise the query. If they documented organ failure due to sepsis, code sepsis, severe sepsis, organ failure. If they not mention the relation, query for the severe sepsis. Next, diabetes and metabolic acidosis. Not mention the relationship. Query for the relationship. Anemia, chemotherapy. Not mention the relationship. Patient ongoing for chemotherapy, patient have anemia. But they not mentioned anemia due to chemotherapy or unrelated. Then we can raise the query for relationship. In these three concepts related, you will get questions in exam. Please note down these three examples under cause and effective related query.
So, first one sepsis, acute organ failure. Next, anemia, chemotherapy, and another one.
DM metabolic acidosis. Here, there, na? These three. Done, guys? Noted, huh?
Yes.
Yes, sir.
Thank you. Next. Next type of query, note down. To seek clarification when it appears a documented diagnosis is not clinically supported, which means they given the diagnosis but there is no clinical support. At that time also we can raise the query for clinical support. We should not code the diagnosis without the clinical support. Clinical evidence, we need to raise the query. Okay, for clinical support, we need to raise the query. To seek clarification when it appears a documented diagnosis is not clinically supported. There is no clinical support, then we need to raise the query for clinical support. If they given only clinical support, based on the clinical support, we can raise the query for diagnosis. It should be clinical indicator query. Next important concept. Read this concept. To resolve conflicting documentation between the attending provider and other treating providers, whether diagnostic or procedural. What is this meaning?
For example, if attending provider diagnosed as chronic heart failure, but the consultant is telling us acute on chronic heart failure, means it's a conflicting documentation between the both. So we have to verify the either which is chronic or acute or chronic.
Correct. For same diagnosis, they mentioned different severities. Okay, same location, they are mentioned different diagnoses. At that time, we don't know what is the exact diagnosis we need to code. Conflict between the providers. Each provider documented separate specificity on the diagnosis. Okay. At that time, you need to raise the query for attending patient for the clarification. What is the exact diagnosis we need to code? Suppose one patient documented obesity, other patient documented morbid obesity. We don't know what we need to code, either obesity or morbid obesity. One patient states renal failure, other physician states renal mass. We don't know what is the diagnosis. One physician states liver mass, other pathologist states it was not mass, it was adenocarcinoma. We don't know exactly what we need to code. At that time, we need to raise the query for clarification. What diagnosis we can code exactly? That should be conflict between the two providers, attending provider and other treating providers. For whom we need to raise the query always?
Attending provider.
Attending provider. Wherever the issue in the document, you can raise the query only for attending patient or attending provider. Admitting patient or admitting provider. Same meaning. Next. Examples note down. This. Pathologist documented pathology, attending patient documented renal mass, pathology documented renal neoplasm. Renal failure, renal insufficiency. Patient documented obesity, consultant document morbid obesity. These 3 questions you will get in the exam.
In that scenario, why not we take attending physician diagnosis?
Because we don't know consultant was whether correct or wrong.
Okay, fine.
Might be every time. If suppose other patient also might be correct, right? We don't know. That's why we need to confirm with again attending patient. You are mentioned obesity, but consultant documented morbid obesity. Please confirm which one is correct, like that. Same. Patient mentioned mass. They sent to the sample to the path report. Pathologist documented carcinoma. Again the path review by the attending patient. If it should be cancer, they will tell cancer. If it should not cancer, they will tell adenoma mass. That's it. Okay. Next query type, laterality query. Laterality query node. Laterality query. Laterality means conflict between the right and left. Why? What type side we can take? Okay. Conflict between right or left. Which side we need to take? It should be specified side. Suppose they given knee osteoarthritis. They not mention right or left or bilateral. What type of query will raise?
Lateral.
Specificity query, right? They given unspecified osteoarthritis. We can look code, raise the query for specificity. Why you need to raise the query for laterality? Laterality, when we need to raise, they documented right and left both. Somewhere right, somewhere left. Conflict between the laterality side. See here, for example, the patient coming with right distal radius fracture, but procedure not performed, radius fracture reduction on the left distal radius. It should be acceptable. Diagnosis documented right side, but procedure not performed on the left side. Can we code diagnosis right, procedure left?
No.
No, right?
Yes.
Because if the patient have diagnosis right, they need to perform the procedure also right side. If they given left side, how it should be acceptable? So somewhere mismatch in the laterality, either diagnosis left or either the procedure right. We don't know which side was mismatch. Which side we need to code, right or left? At that time, we need to raise the query for laterality. Options you will get like code both as right, code both as left, code diagnosis right, code procedure left, and query for the laterality. At that time, we need to select query for laterality. One more example you will get like they will take X-ray performed for right hand. In radiology report documented left hand osteoarthritis. If they taken the X-ray for right side, how they can find the diagnosis left hand? Correct?
Yes, sir.
Yes, sir. So somewhere mismatch. Either diagnosis right or they taken the X-ray left side. So site mismatching. At that time, we need to query for the laterality. If they not mentioned right or left, you can raise the query for specificity. It should be unspecified type they given. So here, mismatch the site, whether right or left. What we need to code exactly, they not mentioned, either right or left. At that time only, we need to raise the query. In this concept, we will get 2 to 3 questions, guys. Like they will give diagnosis and procedure opposite side in the question. One question, cancer related, you will get. A patient coming with right breast adenocarcinoma, procedure performed left mastectomy. How we will code the scenario? One question you will get like right carotid artery stenosis, procedure performed on the left carotid artery. How we will code? Options you will get code both as right, code both as left. Assume diagnosis right side, procedure left side, or query for the laterality. If you see in the option query for the laterality, look that given the diagnosis and procedure same side or opposite side. If they given opposite side, you can select query for the laterality option. Clear?
Yes, sir.
Remember guys, whatever query types we can covered, I will summarize. First, POA indicator query, everybody understood?
Yes.
Laterality query, everybody understood?
Yes, sir.
Yes.
Clinical indicator,
Yes.
cause and effective,
Yes.
Yes.
acuity or specificity.
Yes.
Yes, sir.
These are the important queries, guys. POA related, you don't get question. Clinical indicator related, you will get 3 to 4 question. Cause and effective 2 to 3, laterality 2 to 3, and conflict between the two providers related. Mostly you will get conflict between the pathology report and attending patient report. A pathologist will give different diagnosis, attending patient give different diagnosis. A specificity query, one question you will get. That respiratory failure. Okay, what? Queries. These are the types of queries based on the documentation when we need to raise the query. Now, how to raise the query? Now onwards, very important, guys. How to raise query? Now you understood when you need to raise the query, but how we need to raise the query? Verbal means no problem. Audio message or phone call you will do. Written queries. We can fill the query template and we need to send our concern to the physician in written format. Electronically you are returning. Now there is no paper return. Electronically you will fill the template and you can send to the provider. Then provider also give the response electronically. Okay. Now, based on the query opportunity, we have 3 types of queries, 3 types of templates. Okay. 3 types of templates we have, guys. You can use any one template based on the query opportunity in these 3. Okay. Default we should not raise. Based on the query opportunity, we need to follow in these 3. Note down: open-ended query, multiple choice query, yes or no question type query. These are the examples. When you need to raise the query, open-ended, multiple choice, or yes or no. Noted types, open-ended, multiple choice, and yes or no type. Now I will show query templates. How we need to raise the open-ended, multiple choice, yes or no. This is our query templates, guys. First example of open-ended. Open-ended means free text, okay? Free text, para type. You need to return your concern, paragraph type. Okay, free text. See here, this is the documentation up to here. They raise the query like this. This is the query written. They share the query like this. Based on the indicators, they return the query like this. Right? It should be free text query. Next, multiple choice query. Multiple choice means we will provide to the multiple options to the provider. Options you will give like this. Whatever you are thought, you will give the options. Whatever you are feeling, that all options you will give to the physician. There is no limit for the multiple options, guys. You can give unlimited options. While you are raising the multiple choice query, whatever you are thought, that diagnosis you can mention, and the ending you can give other type. Other option must be document, because if that was not correct, they will give their correct diagnosis in the other option. It should be multiple choice template. Then yes or no template means questioning type. You will give only two options, yes or no. See here they are raising relationship query. A patient is admitted with cellulitis around a recent operative wound site, and only cellulitis documented without any relationship to the surgical procedure. They mentioned cellulitis and surgical procedure, but they not mentioned that cellulitis was related or unrelated. What query you need? Just two options enough, right? It was related or unrelated. That's it. Correct? Huh?
Yes.
More than that, you need any clarification on that? No, right? Just you need that cellulitis was due to surgical procedure or not. Two options enough. Yes, no. Yes means related, no means unrelated. That's it. If you raise the query in the question type, you are providing only two options. Yes, no. Questioning type, it should be yes or no type. You will give the multiple options. It should be multiple choice query. Okay? Then, if you return your query in the free text format, it should be open-ended query. These three templates we are using to lead a query. Okay, we are raising a query. You need to use in these three any one template based on the query opportunity. Do not use two templates at a time for single query. Correct?
Yes.
Thank you, guys. So, everybody understood queries?
Yes, sir.
Yeah. So, next concept, leading and non-leading version. This is the most important, guys. Leading and non-leading. Note down leading and non-leading query. Leading and non-leading. Leading, other name should be non-compliant. Non-leading, other name should be compliant. Noted. So first thing, guys, based on the query type, we can raise either leading version or non-leading version. We should not raise both versions. Based on the query opportunity, you can raise in the leading version or non-leading version. Leading other name non-compliant. Non-leading other name compliant. This is the most important topic. If you understand this topic, you will get 3 to 4 questions. Simple concept, but do not confuse. Leading, first thing. Leading means based on the documentation, you got conclusion for which diagnosis you need to raise the query. No complaint about the diagnosis. You are directly able to lead the diagnosis. Here, how they raise the query, see, the patient has elevated WBC, tachycardia, and given IV antibiotics for Pseudomonas culture from the blood. Are you treating sepsis? It should be leading version. You are identify a diagnosis based on the document and you raise the query for the particular diagnosis and you mention the diagnosis in the query opportunity. But you don't know for which diagnosis the indicators or the document was supported. Okay. We don't know for which diagnosis the document was supported. At that time, how we need to raise? The non-leading or complaint version. Based on your clinical judgment, can you provide a diagnosis that represent for below listed indicators? They mentioned all the indicators here. See, same indicators only they mentioned. And they are asking, please document the condition. I don't know the condition based on supporting data. Please provide the condition. It should be complaint version. We are complaint about condition. We are unable to lead, not able to lead, and we are able to complain. We are able to lead, no complaint. That should be leading and non-leading. Leading version, you will get the diagnosis name in the options. In complaint version or non-leading version, you don't get the diagnosis name, you will get just documentation. It should be complaint version. One example I will show, you can understood. Check third question. It should be complaint or non-complaint.
Non-complaint.
This is the question. From here, coding professional was creating a query. This is the documentation. From here, coding professional raise a query.
A option.
It was complaint or non-complaint? First identify.
Non-complaint.
Non-complaint.
Non-complaint. Why? They are asking it was a complaint query or not. Complaint query or not. No means option B or C. Yes means A, D. It was a complaint version or non-complaint version. First tell me.
Complaint version.
Complaint version.
It was a clearly complaint version, right? A coding professional sent to this query. Dr. Reynolds, based on the X-ray finding, lung infiltrates, potent culture positive for Klebsiella and the discharge mentioned piperacillin. Can you identify the condition that was being treated? Where the coder mentioned the diagnosis name? Just they given the indicators, right?
Yes, sir.
It should be complete. Now only I say, if you give indicators and ask the condition, it should be non-leading or complaint version. If you mention the diagnosis name, it should be leading or non-complaint version. Suppose. Identify the fourth question. Option A correct, guys. Okay. It was a complaint query. Fourth question. Examine following query, determined if it is complaint and why. They are asking it was a complaint query or not.
No.
No, sir.
No, they mentioned the acute blood loss anemia right here.
Yes.
So it should be not a complaint query. No. Okay. These two eliminated. No, because the query is leading. It was directly leading, but inappropriately includes the term possible. While you are raising a query, do not mention I am suspecting the diagnosis like that. You need to give confidently whatever you are finding the diagnosis. Whatever you are think the diagnosis you mention directly. I am thinking the diagnosis possible, probable. Do not mention in the query. Give the diagnosis straight. Are you treating post-operative blood loss anemia? Like that we need to ask. So yes, because the query is leading. inappropriately include the term possible in the question. Okay. It was a leading query, not non-leading query. Clear? Now you get idea, right?
Yes, sir.
Thank you, guys. I shared the 30 questions provider queries with explanation in your group. Go through these 30 questions. Ending, we have the answers and explanation. Tomorrow, I will discuss all the 30 questions with you. Whatever you have doubts, we can discuss the provider queries. Okay. Your questions, every question I will explain this 30. If we understood these 30 questions, almost you will get the questions in this type only. Not exactly, but in this type only we'll get the document. Clear?
Yes.
Yes.
Okay, guys. Thank you. For having doubts, you can ask me. There is no recording because already I shared the recorded sessions. Watch it. Okay.
Thank you, sir.
Thank you, guys. Then bye bye. We can connect tomorrow for queries remaining concepts.
Thank you.
Thank you.